if you've had a heart attack, whatever your cholesterol was the day before your heart attack was too high. And we know that high LDL-C cholesterol and some other cholesterols go on subsequently to cause heart attacks, just like blood pressure and diabetes do. We know it's treatable. So whatever your cholesterol was, it's got to be lower than it was yesterday. That's the first thing.
There are some genetic causes for high cholesterol that run in families.
If the family history is still very positive, if there's still loads of people in that family that have had heart attacks and they don't have positive genetic high cholesterol, we're still looking for some inherited causes because there's still a family history.
They're a teenager and they've been told they've got high cholesterol because that second group, the younger people, could suggest maybe there's a genetic component. So
really what often happens is we find that someone of a young age has had a problem, has had a heart attack.
There is a registry that's set up in India a couple of years ago to try and track how frequent that is. It's called hypercholesterolemia. It does look like it is diet. You know, the Indian diet is full of things that contain high cholesterol. That's perhaps why Indian foods is so tasty.
Diet's going to feed into loads of other bits of metabolism. It's going to change how your sugars work. Many of the other bits of cholesterol I've just been talking about, they're affected by diet and they can cause heart attacks.
Welcome again to Delhi Belly, a series of conversations around preventative health for people of Indian origin. My name's Nikhil Alawalia. I'm a cardiologist and researcher in cardiovascular health.
I'm Abhishek Joshi. I'm a consultant cardiologist in London.
And today we're going to be talking about a hot topic again. We're going to be talking about cholesterol.
Oh yeah, okay.
Yeah, there are a lot of debates, controversies, but there are a lot of things that we know about cholesterol. And so let's start digging into that. And again, I'm going to open with a scenario. So let's say you have a 60-year-old man who is in India, had some chest pain all of a sudden, and has had to go into hospital for a heart attack. He gets treated, gets a stent, does very well, is seen in the clinic 6 months later for a review. At that time, he's having blood tests, which include a cholesterol level, and his cholesterol level is 4.8. He's heard loads of other numbers, of which he's told that the LDL is an important one, and that's 2.5.
Yeah.
So why don't you start by just giving us some thresholds, some values that we should be looking out for when we're having our cholesterol checked for this gentleman and I suppose more widely as well.
So the first thing to say, and it's really important, is that this person has had good treatment. Earlier on in our series, I don't know if you caught the one about a heart screening test, right? We were talking about people having heart screening tests and finding thickenings of the arteries and then wondering whether they should have a stent. And it's really important to know that this is when you should have a stent. So what has happened for our patient now is that they've had a blocked artery. It caused them pain. That was a heart attack. You can tell that they've had a heart attack from some blood tests and the ECGs, which is the electrical tracings of the heart. It's a medical emergency. They get taken straight to hospital. And at that point in time, sometimes during the heart attack, whilst it's happening, if it's a very severe one, sometimes in the day or two afterwards, when things have calmed down a little bit, depending on how emergency things seem to be, a stent is exactly the right treatment.
Fine.
Stents save lives in the context of heart attacks. And it's really important that everyone recognizes that. So where you might say, well, should I really have a stent if you've got no symptoms and it's just because of some thickening on a CT scan? In this situation, there's very little room for negotiation.
Black and white.
It's the right thing
needs to be done.
It's as close to black and white as it comes in cardiology.
Okay.
And you shouldn't wait around for a couple of months deciding whether to have it in that specific heart attack situation. The next thing to say is that it sounds like he's had good testing done afterwards, right? So they're checking to see if there are any things that we can do now to prevent a future heart attack. Because really what you don't want is another one, right? Okay, you managed to survive that first one and it's all great news. Hopefully the heart's still in good shape because you've got good prompt treatment. But really the aim of the game now is avoiding another one of those. And as soon as you've had one of those, you're suddenly at much, much higher risk. All the risk scores we talked about before go out the window. You're just someone who's got a really high chance of having another heart attack. You've got to be almost superhuman to avoid another one in your lifetime. And that's the sort of thing that we like to achieve with patients who've had heart attacks. So I just want to set the scene. It's really important that you get good emergency treatment if that's what happens, if you feel that chest pain. But now we're afterwards, we're thinking about how to prevent things. And he's talking about his cholesterol in particular, right? So remind me, the cholesterol level was 4.2?
4.8, let's say, whatever.
4 point something. Okay. It's important to be precise. And what that's a measurement of is, well, what's it a measurement of?
Well, I mean, so he's had a total cholesterol done as part of a lipid profile. And so as part of that, there are lots of different numbers that are given to you, of which total cholesterol is an important one.
Yep.
This is a measure of the number of cholesterol molecules, the concentration of those flowing around in the blood. Now, not all cholesterol is equal. And in adverts for food, you'll hear about good cholesterol and bad cholesterol. Right. And specifically in this scenario, we're focusing in on the LDL cholesterol, which is also called the bad cholesterol. And that's what is associated with flowing fatty molecules of cholesterol from the liver to other parts of the body, and that's why it builds up in the arteries in the heart. So that's why it's important to bring those values of cholesterol down, and I guess that's also reflected in the total cholesterol, which is why looking at both can be important.
Exactly. So the total cholesterol level, which you might see in your blood test results, that's a measurement of all the cholesterol in your blood. And cholesterol is basically the way that the body moves stuff that's made of fat around, because it uses it as fuel and as building blocks for stuff. Like, we need these things. They're part of our usual biology. We probably don't need as much as we have floating around in our blood as we get older. You can build a baby like with quite low cholesterol levels, right? Babies don't have high cholesterol, and you can build a whole human being with it. So you don't need it that high, but it is an important part of human building blocks. It's not, you can't just delete all cholesterol and survive. You need some of it around. And again, as you say, it's split into different chunks, but those splittings are kind of done by science, right? In the body just kind of tags things and sends things around, and it's got this beautiful way of handling cholesterol and moving it around the body.
Yeah.
You talked about LDL-C cholesterol. I can't believe it, but there's still controversy about LDL-C. Like, it's amazing that people are still able to kind of draw out controversies, and I'm sure you're going to do it.
What's the controversy?
Well, firstly, I think there are some people out there who have said that that's not the thing that causes heart disease. And I think in modern Western medicine in particular, the idea that LDL-C, so that's low density lipoprotein cholesterol.
Okay.
So that the reason it's called low density is if you just spin your blood around, it goes to a particular point when you spin it around, and you can just see that cholesterol, a layer in the blood test. That level of cholesterol, that's the level that most closely tracks heart disease risk.
Okay.
There are some others that do also cause heart disease. We'll talk about that, but that's the one that most closely tracks it. It's also the one that we've got amazing treatments for to reduce, that then prevent heart attacks in the next decade or next 5 years. So the controversies are, some people just don't believe that, and it's very difficult when looking at modern medical evidence to see why they don't. But, you know, it makes for good podcasts, right? And it gets good engagement. So you get to say controversial things about cholesterol, and that can sometimes attract eyeballs and can sometimes attract people's attention. And that introduces uncertainty into people's minds, particularly if they don't have access to a good explanation themselves. There are some good scientific controversies. There are some good questions to ask about LDL-C cholesterol, low density lipoprotein cholesterol, that we could talk about, that I'm really interested in. But the simple fact is, reducing your LDL-C is a really, really good way to reduce your risk of heart attack in the future.
Let's start with that before we get into these controversies. So I think another point that's almost close to black and white is that if you've had a heart attack, we should start thinking about whether you should be on a statin.
Yeah.
And that's almost, again, a recommendation, because we know from very large randomized trials in the UK, and again, for people who haven't heard the previous podcast, randomized trials are when you take a large number of participants and you split them up into two groups and allocate half of them one treatment and compare them to another group who don't get that same treatment, who get a different treatment. And we know that people who've had a heart attack who are on a statin do better, live longer.
Yep, we do. And we know in particular which statin and which dose after a heart attack as well. That's really important. So the randomized control trials, including some really big international studies, found that atorvastatin, 80 milligrams, is the best medication to take if you've had a heart attack. That's just it's as close to black and white again as we can get. So again, I can't give you medical advice as an individual, right? And of course, this person isn't a real person, right? They're thankfully an imagined person that's had a heart attack. But anyone that's had a heart attack is going to hear from their cardiologist that taking that statin at that dose has got the best evidence for preventing future heart attacks. And so after a heart attack, that's what we tend to recommend. There are many statins, and I guess we're going to come on to talk about those.
Well, let's talk about them now, because I think, this podcast is tailored to people of Indian origin,
right?
And interesting to hear the data around atorvastatin and that being, the one that's used in the trials. But would that extend all the way to people of Indian origin as well, or are there other statins that may come closer?
In my experience, people of any origin get good cholesterol lowering and I've got the most faith in reducing their risk of heart attack with that, because there's clinical trial data to support it. Other statins seem to work differently across ethnicities, but it's very difficult to pin down. The degree to which people have done lots of research into this is quite narrow. One example, for example, is rosuvastatin. That's rosuvastatin. So that's a really potent statin. It's got similar potency at lower doses to atorvastatin. And in people of South Asian origin, so Indians, actually the maximum dose you can use for those people is lower, because the risk of some of the side effects that people get from statins are higher at the sort of higher doses that we normally use in Western medicine. So Indians and South Asian patients, there is a feeling that we ought not to give them more than 20 milligrams of rosuvastatin. I have great results with it in my practice at that dose.
Yeah.
But I'd still prefer the atorvastatin if possible, because there's much more data for preventing heart attacks in the future in this context of people who've had heart attacks.
Fine. So I think what's important to talk about here is that after you've had a heart attack, almost regardless of what your cholesterol level is, you should be on a statin. Maybe there's a few exceptions, but the statin is gold standard there. Now, if you haven't had a heart attack, and so let's say primary prevention, which means looking at preventing the first heart attack, I guess here things are a little bit grayer, and we don't have the same level of evidence that everyone should be on a heart attack. It shouldn't be in the water, and you do have to go for measurements and look at the number of your cholesterol and try and bring that down in some circumstances.
Yeah, okay. So let's take those two cases separately, right?
Yeah.
If you've had a heart attack, whatever your cholesterol was the day before your heart attack was too high, right? Because the following day you had a heart attack. And we know that high LDL-C cholesterol and some other cholesterols go on subsequently to cause heart attacks, just like blood pressure and diabetes do. We know it's treatable, and we know you just had a heart attack. So whatever your cholesterol was, it's got to be lower than it was yesterday. That's the first thing to say.
That's clear, yeah.
The second thing to say is that you subsequently had a heart attack, and we know that the thickenings and the likelihood of a heart attack in the future are related to what your LDL-C is. So you now need to be superhuman. You need to have a lower than normal human cholesterol level, lower than normal human LDL-C, if you want to prevent a heart attack, because you're now someone who's at risk, right? And if you want to get back to being someone who's not at a really high risk of a heart attack, you've got to do more than the average person does, because you just had one. So those are just the heart attack things. That's what this case is about. You were asking about people before their heart attack.
Yeah.
Is there a number that we target? Yeah, there kind of is. There are a bunch of thresholds that you might go for. You can individualize them. What we like to do in the United Kingdom is to half your cholesterol. So if we think you're at risk of a heart attack, and we think we're going to give you a statin, and we talked about this in another episode, and you can go find it. If we start a statin, the target is to half people's cholesterol. So whatever it was, it needs to be half of that. Or you can start looking at targets for LDL-C. Those targets aren't fixed in guidelines in the same way that they are for people who've had a heart attack.
Fine. Now, that's really helpful to understand why we look at LDL-C and these numbers. But I'm hearing more and more about the different other molecules that are involved in lipid profile panels, and family from India and even in the UK are messaging me about APOB, what that is, whether we need to have it checked. And sometimes these names can even get confusing to me. LP little a and APOB, LDL-C. Is there any of these that are relevant to us?
Okay, well, obviously to me they're all relevant, but let me just talk you through how it works. Right, so you eat some food. Let's say afterwards we go have a biryani or something, and that's got a lot of fat in it. So immediately after that, our blood will be full of these little blobs of fat called chylomicrons, or they're just like the fat straight from food. It floats around your blood, and then it gets taken up by the liver and packaged up into a little ball of fats and proteins. Think of it like a pakora. Am I allowed to? Let's think of it like a little blob of something. It's a mixed up stuff.
A pakora,
like great. A pakora. Loads of fat in there, but there's also some vegetables which you could think of as the proteins. Like I don't know. You were telling me earlier on your mum didn't put peas in her pakoras, but my mum I think did. Maybe that's the difference. But so there are these little other things that are kind of like proteins in the balls of fat. And those go around the body, and the body processes them at different places, and eventually they get turned into these tiny little balls that go back to the liver and excrete the cholesterol. So they've all got different names. The biggest ones are called triglycerides, right? And that's a measurement. You'll see that on your lipid panel. If you're looking at your lipid panel right now, triglycerides, those are like fats. And some of the little proteins, the proteins that make up those triglycerides, they can cause heart disease, some of those. A little bit later on in the processing, you get this thing called the LDL-C, the LDL molecule. So that's a combination of cholesterol, and you talked about APOB. That's a single protein. It's probably the only protein in that molecule. So basically it's fat with a few P's in, and the P's are APOB. And the APOB can be measured separately, right? So you could measure how many P's have I got in my blood, right? Or you can measure how many pakoras have I got in my blood. And of course, if every pakora has got 3 P's, then you're going to get 2 different measurements. Now, some people's lipid particles have, so their blobs or pakoras have got high numbers of apolipoprotein B, ApoB, the protein in, and some people's don't. And this is where one of those controversies come in. I think you've got a bit of data about Indians and ApoB and VLDL, right? And remember, we're getting really technical here, so we've got to make sure that we don't blind people with too much science. let's try and keep it as clear as we can.
So again, I thank you for that Pecora-related analogy. And I guess sticking to that, you're talking about the APOB inside the LDL, and we've got data from pretty large studies done in ethnic communities. So the MESA study, the multi-ethnic study of atherosclerosis, that looked at people from Indian origin and compared them to other groups. And they found that people from Indian origin had a almost 15 to 20% higher incidence of APOB. And we've been speaking over the last few episodes about how coronary disease and all these heart problems are much higher in Indian people. And I guess one of the theories could be that the higher APOB content in Indian people may be linked to that.
Yeah.
And I guess that's interesting from a scientific point of view because it partly explains that. But I suppose the question that follows on from this is, okay, someone has got a high APOB. Can we do anything about it?
Yeah, well, what are you going to do about it?
Well, I think you've got to first of all think APOB is one part of that Pecora.
Yep.
And also reducing the amount of Pecoras in the blood will reduce the amount of APOB. And so let's get that down.
Yep.
And you've already spoken about how well some statins can do that.
Yep.
And so I think taking a bigger picture, rather than targeting the APOB specifically, let's just clear out the Pecoras from the blood.
So let's put it like this. If we didn't have 5 or 6 incredible treatments that were amazingly well researched, probably the most researched drugs in the world, great safety profiles. Yes, they have side effects sometimes. Then we'd need to invent some new drugs, right? Maybe we'd be targeting apolipoprotein B. But because we've got amazing drugs that reduce the Pecoras, right, and not just the P's inside the Pecoras, we can deal with that. And those amazing drugs are statins. I don't want to say it's boring to be someone who's really positive about statins. Like, you know, actually you get much more engagement and people want to talk to you more if you anti them or you have some sort of skepticism about them. But they're really good drugs and they work really well. So you're totally right. There is possibly some difference in the science between how the P's or the ApoB or the Pecoras cause heart disease. But in the end, we've got a drug that reduces both of them at the same time. So that's why we use statins. There are some other drugs, and some people can't tolerate statins. They get side effects. I suspect that's a whole episode.
Before we go on to those other drugs, I think we should emphasize what you've just said is that statins are not sexy, but they work. And they, we've got decades of data about how good they are. And so often if you look online, you'll hear about this new cutting edge drug, this injection that has X% effect, but what works and what we know works and what's safe are statins in the vast, vast majority of people. And so before we go hunting for the next step, you've got to make sure, especially if you've had a heart attack, you're on that maximum dose, that 80 milligrams of atorvastatin, before you start exploring whether you need anything else.
Totally. And you do need to meet some specific targets in a heart attack. So we talked about LDL-C levels and halving it in people who haven't had a heart attack yet. But the recommendation is to get as low as you can, and certainly below 1.4 millimoles per liter. That's the units for LDL-C. And actually, increasingly, we're trying to get people below 1.0 millimoles per liter. And just to give you a sense of what that means in the general population, like most people's LDL-Cs are like 3. So we're trying to get people who've had heart attacks down to a kind of superhuman level of protection. We can't let them just hang around being average anymore. You just, once you've had it, you can't take more of the risk if you want the best possible healthcare outcomes. And you're totally right. Like, it's really hard to be interesting about statins. People look at me as a cardiologist like, you're interested in statins? What about all these cool things that we can do? But because it's so life-saving, if you get it right for the right people, I still find it really interesting. I guess drop us a comment. Do we have comments on this podcast?
Absolutely.
Drop us a comment if you want to hear more about it. We can spend years talking about this stuff.
I think it's important to say that there are other options, because you may well be told by your doctor, yes, your LDL-C is controlled, but you've got a high ApoB. And again, as far as I'm aware, there isn't a licensed drug that specifically targets the ApoB. And so the strategy that a doctor may take is to try and bring your cholesterol down even lower if it needs to come down. So again, to target high ApoB, you target the full Pecora, target the cholesterol levels, the LDL levels, by bringing that down with second drugs if you need to.
That's right. I think we should still focus on the LDL-C here, because it's the same. Apolipoprotein B and LDL-C, from a treatment perspective, we're giving the same treatments. And there are some treatments that we can do in addition. Some are still in trial, but have been licensed by NICE in the United Kingdom. So there are some drugs like inclisiran. That's an injectable drug that can reduce LDL-C. And we're still waiting to see if that reduces heart attacks in long-term studies, but we're pretty confident it will. And the people at the NHS have decided, and we've been using that medication for quite a while now. We've got good experience. The drugs that we've got even more experience with and have got good evidence for reducing second heart attacks through reducing LDL-C, so reducing that bad cholesterol, if you like, are PCSK9 inhibitors. So those, don't worry about what PCSK9 stands for. Definitely don't ask me. But those are injections that people take twice a week. And they reduce your LDL-C too. And they can, in addition to statins, or sometimes if people can't tolerate statins, just instead of a statin, that's got really good evidence for reducing LDL-C and therefore reducing heart attacks. So in our specialist clinics, we sometimes use those medications to get people to that superhuman level to maximally prevent the risk of heart attack.
Fine. And I know that there are some genetic causes for high cholesterol that run in families. I've read in my research for this episode that there is a registry that's set up in India a couple of years ago to try and track how frequent that is. It's called hypercholesterolemia or familial hypercholesterolemia. And that looks like it's sort of a similar sort of rate in Indians and non-Indians, because one of the things that I explored was whether that could explain why Indians have higher cholesterol.
Right. Is there more familial hypercholesterol?
Yeah, and there's nothing really supports that. It does look like it is diet. You know, the Indian diet is full of things that contain high cholesterol. That's perhaps why Indian food is so tasty.
Well, you've got to remember, it's not just cholesterol, is it? We've been talking about it because that's what the topic of this podcast is. But diet's going to feed into loads of other bits of metabolism. It's going to change how your sugars work. Many of the other bits of cholesterol I've just been talking about, they're affected by diet and they can cause heart attacks. But we just don't have as good treatments for them yet, so we don't focus on them quite so much. Let's flip the script on your 60-year-old. Now he's 40 and he's had a heart attack. So because you were talking about genetic causes. Story's very different once you're 40, right? That's considered to be premature coronary artery disease.
And that's because you said that, well, we said in an episode previously that cholesterol or problems that happen in the heart arteries accumulate over a decade, or several decades. So if someone is 40 with a heart attack, that means they've probably had significant disease building up over a decade.
Possibly longer.
So why should someone at such a young age have coronary disease? And that should set alarm bells off if they're young.
Great question. Yeah, good point. Exactly. So if you're 60, maybe it started when you were 30, it took 30 years to happen. But if it's going to take 30 years and you're 40, then it had to start happening when you were 10. Yeah. Right? And that's very unusual to have high cholesterol when you're 10. Yeah. Or other risks of heart disease. And so that does trigger an alarm bell. If you've got a family history of people who've, patients with lots of people in their family who have heart disease at a young age, and 40 is a young age, maybe there's something genetic. And familial hypercholesterolemia, about 1 in 200 people have it. So if I took 200 people in a room, there'd be one person with familial hypercholesterolemia. But if you're in a family where one person has got familial hypercholesterolemia, you've got a 50% chance of having it if you're related to that person, genetically speaking. That means that in a family, half of the family are going to have it. And they will get very, very high cholesterol from birth. Okay. And that can then manifest as much earlier heart disease. The treatments are statins, and we often start this at a young age. But particularly in the UK, if they have a heart attack at a young age and the cholesterol's over a certain level and there's a high degree of suspicion in the family that there's a lot of family history of heart disease, then we would offer testing and treatment for other members of the family too. So we can prevent another 40-year-old having a heart attack. It's such a devastating thing in a family. For that person, they're working, they're a father of young children potentially, or a mother of young children. Suddenly they've had a heart attack and they're debilitated. We really want to know that that's not going to happen to more members of the family.
So if you are of Indian origin and you've got family members with high cholesterol, it matters whether they're 50, 60 and they've got high cholesterol versus whether they're a teenager and they've been told they've got high cholesterol, because that second group, the younger people, could suggest maybe there's a genetic component. So,
and then remember, we don't normally check teenagers. Yeah. So really what often happens is we find that someone of a young age has had a problem, has had a heart attack. Yeah. And then we go around and check the rest of the family. Sure. Once we've tested that person, we check for that person first, because they're the person that's had the heart attack. And if we don't find that they have the gene, then we tend to relax about the rest of the family sometimes. But if the family history is still very positive, if there's still loads of people in that family that have had heart attacks and they don't have positive genetic high cholesterol, we're still looking for some inherited causes, because there's still a family history, right? We still need to think about some other stuff. Fine. So there's a couple of other cholesterols maybe we could come on to talk about that also seem to run in families. What do you think?
Yeah, I think we've talked about a lot, so let's just cover that again to make sure that's clear, because it sounds like there are some things which are clear, which is if you've had a heart attack, you should be on a high dose of a statin. It doesn't matter what your cholesterol level is.
Yep, if you can tolerate it.
If you can tolerate it. Yep. And if you have not had a heart attack and you're wanting to manage your risk profile and you're an adult, you should have your cholesterol level checked, and that is what will determine whether you need to be on a statin,
or some other medication. Yeah, we could do a whole episode about that later. Yeah.
Great. And I think the other thing that we said is that if you've got a family members with high cholesterol at a very young age, then you need to start thinking about, is there a genetic component, and test more broadly. Yeah. Especially if that leads to heart attacks at a young age as well.
Exactly, yeah. And perhaps we'll talk about the other forms of cholesterol in another episode. But the real lesson here is that if you've had a heart attack, there are some things that are mandatory, right? So you have to take an aspirin. If you've had a stent, There's another medication that often goes along with the aspirin to take for at least a year to prevent that stent from blocking off. And doctors will tell you about this when they put in the stent. We're very particular about the exact medications you should take because, of course, it is a complete disaster if the stent blocks off. And it's a possibility, which is why we give these people medications to prevent future heart attacks, but also problems with the stent. A statin, I think, is also pretty much mandatory. And then knowing that you don't have diabetes, and if you do, having that treated well, and knowing that your blood pressure was well controlled, those are, and if not having that treated, that's the package. After you've had a heart attack. And then, there's a bunch of other things. If you have the consequences of a heart attack, you think about, that's a completely separate conversation, I think. But those are the mandatory things after a heart attack. And if you're young, you need to know that it wasn't from a genetic or inherited cause. A lot of that's about thinking about if other people in the family have had it and then thinking about further testing if we need to do it.
Got it. I think that's great. I think we'll leave it there today and hopefully given some good lessons on cholesterol.
Cool.
Thanks.
Before we start, why did you call it Deli Belly?
Just a good name. Should we do it again?
I thought you might have a good answer for that question.
Yeah, it's just a good name.
All right, yeah, it's a good name.
This is the podcast name first, ideas.
Okay, right.